trochlear ridge as much. So the old surgery, which is still done in some cases now, is to cut that ligament entirely. So medial patellodesmotic is just cutting the ligament. Now, if you have the horse that's permanently locked, you know, like that second video we watched, that you can't even get him to take a normal step, that's a horse you'll have to cut the ligament. Okay? But that's the rare case nowadays. So if you have a horse that's not locked like that due to patella ligament splitting or fenestration, reserve cutting the ligament for your really bad cases, because it does destabilize the spine. Okay, so this is our next one that can be confusing with the locking step. All right, so sternum. Now, this is a neuromuscular thing as opposed to just an anatomical thing, like the upper fixation. So this is a rapid involuntary flexion of a hind leg, one or both. Worse when turning, worse when backing, but let's watch the video and you can see the difference. So he kind of just can't put his foot down. You know, as he starts out especially, he'll just pick it up. He's affected on both sides, and he's just stuck up there. It's like a little nerve reflex, just keep him there. Can you see the difference? Okay. Those upper fixation horses, sometimes when they finally release, they'll snap up a little bit, but they're not doing this. This horse is just coming up. He's never locked. He just comes up and then he keeps it down.
Was that from the lateral digital extensor?
What's that?
Was that damage from the lateral digital extensor?
It's a little more complicated than just direct damage to that, but you're on the right track for that. Let's keep going. Okay, so two forms. Idiopathic means we don't know what the hell's going on, and the Australian form, which we have an agent for. It's a plant toxin, basically. So idiopathic, it's been reported everywhere. Usually just one hind limb can get worse over time, and then we don't really know what's going on, besides the fact that we think it's a neuropathy of some sort. The acquired form, or also called the Australian form, is usually both hind limbs, and it's related to toxic plants. So all these little dandelion type plants here, and it's been reported in a bunch of places: Australia, New Zealand, North America, Brazil. But it's a little bit more specific than the idiopathic. So, and this is a neuropathy. It's a widespread, interestingly, neuropathy. They've been able to find. So not just specifically in these extensors that are affected, but more widespread in the body. But you do end up with issues with the extensor tendons, which cause this to happen. So it's atrophy of the long digital extensor, lateral digital extensor, and gastrocs. And then, I think this is cool, 60% of those horses also have lesions in the left recurrent laryngeal nerve. Do you remember thinking back to roars, Dr. Parra talking about that? So that's that nerve that gets affected there. But isn't it interesting how something in there is it's affecting like all the sides of the horse, but you're seeing it as this odd gait abnormality. So treatment for the acquired string halt often recover spontaneously. Take them out of that pasture with those plants. They can take a while to recover, years, and they may not completely go back to normal. Now, we are supposed to not do surgery on these if you read the textbooks. I'll tell you a lot of places that have a lot of this. People are not interested in waiting years, and they will just ask for surgery, which does help some of the horses. The idiopathic string halt, where we don't have a plant toxin reason, they don't generally respond to just time. So the surgery for that is a lateral digital extensor tenectomy and partial myectomy. I have a couple slides with the surgery in here. You're not responsible for knowing that. I took my slides. I had another talk where I actually was talking to surgeons and stuff. So don't worry about this. I'm just going to quickly show you because the slides are here, but you do not need to memorize the slides for your thing. So the idea is that you're going to remove 2 to 10 centimeters of the lateral digital extensor, which you can see. Here's the muscle belly of it. Here's the tendon. It kind of goes all together there. and then blah, blah, blah. Don't worry about this part. So basically you're just cutting those and pulling it out and taking it. Again, don't worry about this one. So acquired string halt, fair, none of these things are great, you know. Interestingly, some of these, it works on some horses, some it doesn't work on. So if you use surgery, that is. The acquired string halt, they may recover spontaneously themselves, some don't, or take too long. The idiopathic surgery works on some horses, not well on other horses. All right, we're going to jump topics. So now we're talking about tendon laceration, so trauma to the distal. You guys remember me harping on the fact that there's not a lot of soft tissue in the distal limb of horses. So when you have an injury there, like a wire injury or something like that, you're often going quite quickly to the important tendon structures. So the back of the limb, palmar or plantar aspect, has most of the important stuff. Okay? So if you have an extensor tendon laceration, you get called out to look at this laceration, and that's what you find. The extensor tendon is cut through, you breathe a sigh of relief, because it's a lot better deal than when you get called out and you find that the back part of the limb has been lacerated. So extensor tendon lacerations we'll talk about very briefly, but they rarely have long-term functional consequences. Horses can learn to walk quite well without extensor tendon. So we have 3 different structures that have been lacerated here, or 3 different combinations of structures. So I want you to place, or understand what the leg will look like if this specific structure is lacerated. So to start with, we're going to do just the superficial digital flexor tendon. So there's a laceration to the back of the leg. It only extends through the superficial. It cuts the superficial completely, but the deepest sign is the flexor. So the picture on the right there in yellow goes with it. So what you'll see is that the fetlock just drops a little bit. Drops relative to like the other way. But it's walking over. Well, but it can do it. Alright, so when you have the deep digital flexor tendon as well as the superficial, you get the little bit of drop of the fetlock from the superficial, but deep is no longer able to pull backwards on that coffin bone like it usually does, so your toe flips up. Okay? So if you have toe flipping up, that means you have deep digital flexor tendon. Now if you cut through everything, superficial, deep, and suspensory, this is just a complete breakdown. So you can see there's absolutely nothing supporting that, the distal part of the limb, and the whole from the pastern onwards is on the ground. Alright, so just another way of looking at it. Superficial just drops the fetlock. Superficial plus deep drops the fetlock plus the toes up. And if everything's cut, your leg is on the ground. Alright, so what do we do? Emergency treatment, and we'll talk about this more after I finish this lecture and go on to the fracture stabilization. Biggest thing you're going to do is stabilize the limb. Prevent things from getting worse, while you're trying to move it and evaluate it and stuff like that. So prevent further damage, especially if there's like nerves and vessels that are involved too. Making sure that that limb is stabilized as much as possible. When you have a flexor tendon laceration, one of the things that's really nice to use are these Kinsey splints. I think I've showed you Kinsey splint before, right? Okay. So a Kinsey splint is a really nice thing to have in your truck, and you just put it on. If you have an extensor tendon laceration, remember this is not as big a deal, so just a nice bandage. Heavy bandage may do enough, and sometimes with a splint will help them all. So when you have a flexor tendon laceration, you may or may not need to suture this. So a partial laceration may do okay without a suture. He'll have problems, but if he's lacerated less than 50% of the suture, you may be able to get away without closing that tendon itself, which can be good because you wouldn't have the foreign material in there and the horse is trying to fight infection. Common suture patterns used for suturing the tendon is 3-loop pulley and the interlocking loop. benefits to the interlocking loop is that there's not as much exposed suture material outside of the tendon. Okay? And the 3-loop pulley is really good at preventing distraction, preventing the tendons from pulling apart. If you can't oppose them at all, do the best you can, debride them, take the junk out of there, put a cast on, close the wound, and, you know, see what it ends up. So after repair, a cast is really, really important because tendons and ligaments take a very long time to heal, and they regain their strength very slowly. So at 6 weeks after the tendon repair, the breaking strength is about the same as just the weight of the horse. Meaning, just if he's even standing there in that stall, that may be enough weight to disrupt your repair. Okay, so you know, a prolonged period of cast wearing on these guys. Monitor them as they're coming over this, and a lot of these flexor tendon lacerations are not going to be coming back to athletic use. They're going to be trying to save the life of the horse or make a low-level horse out of it. So 8 to 12 months before athletic function is resumed, and you know, about less than half of them resume to athletic function of some sort. Lots of complications.
So if it goes down to the suspensor ligament, are fractures common with those? Because it seems like their bones kind of hit the ground if they fall on it.
Yeah, I mean, you worry about whatever trauma caused them to be doing that to begin with. Absolutely, you want to X-ray. You know, if there's that much trauma, absolutely there could be a bone involved. Even if there isn't, you may be thinking about arthrodesis of the fella just to be able to allow that horse to stand, and then you have like all the mess of infected tendon structures on top of that, and suturing tendons. That's a really big deal. I don't know how many of those horses would be receiving treatment. So those are the specific types of tendon injuries I want to talk about. We'll go back to basic tendon and ligament injury and healing during that, and just general repair terms. I think we talked a little bit about this, or I know you guys have talked about this back in second year. I'm not going to spend a lot of time going through what happens in the inflammatory, reparative, and remodeling phases, because I think you covered that in the past. But just be aware that there are these 3 phases, and they do tend to overlap. And for tendon and ligament, they can take a very long time. So 6 to 12 months or more for tendon and ligament. This is not like skin. This is not like bone, where they can heal relatively quickly. This definitely is a harder tissue to repair and remodel than bone. So slow to heal. And then the other issue is that it's not going to be able to create a tissue that was as strong as the original. So it's functionally deficient compared to normal tendon. So you remember your normal tendon, how it's organized. When you have a repaired tendon, it's not going to ever be as good as the original tendon. What happens is that it turns, the healing tissue doesn't just lay down that same normal type 1 collagen in the same structure. It will lay down scar tissue instead. We'll talk about those differences a little bit. So in general, when you have the scar tissue, you have a lot of it. If you remember the chronic ultrasound image, much larger tendon than what you had originally. So you're going to have large amounts of these the scar tissue. It's going to be a stiffer material. It's disorganized. It's basically not as functionally strong as the original. So even though it's weaker initially, so it's weaker initially, and then you can have re-injury at the original site of damage. So re-injury at the scar itself. But after the injury gets more mature, as time goes on, the injury is actually more likely to occur at the junction of where the scar and the normal tissue come together. So injury at the adjacent site, so right next to where the original injury was. So as you can imagine, this is going to cause reduced performance, re-injury. One study looked at superficial digital flexor tendon injuries and showed that 56% of these national hunt, which is like steeplechase type racing, and 66% of flat racing, like what we consider thoroughbred racing horses, will re-injure that same tendon. So a lot of these horses have an injury, you think they're ready to go back to work, and then they just re-injure. So ideally, when a tendon repairs, it's going to have filling in quickly of the defects. It's going to maximize the normal material that it originally had, that type 1 collagen. Have nice organization, be very elastic, have very little scar tissue. So the goal is to produce a repair tissue that's much more like the original, less like scar. And of course, we want these horses going back to work. We don't want them hurting themselves. Traditionally, we do things like cold therapy, like NSAIDs, gear bending, ultra bandages, support bandages, resting them, controlled exercise, and those are all still really useful parts of treatment, although we have some newer and more exciting methods we'll go into in a little bit. Cold therapy actually has scientific benefit behind it. It's not just the idea that we're running cold water over it. But what it really actually can do is increase the basic constriction, decrease the enzymes that are maybe breaking down some of that tissue and causing more inflammation, reduce the formation of the inflammatory mediators, slows down nerve conduction and pain. So what we recommend is 20 minutes of cold hosing a few times a day during the acute phase of the injury. Compression bandages, you've all put these on, so we won't go into detail. We often call them a Robert Jones bandage or a modified Robert Jones. Basically just means a thick bandage with lots of layers of bandage material. The idea behind that is that you're reducing the inflammation, you're squeezing out the edema, decreasing that the amount of material between the cells, which can help healing, deal with that edema, by increasing the hydrostatic pressure. Controlled exercise. One of the biggest issues we have is that horses re-injure themselves, because a lot of times they're going back to work before they're really ready, functionally ready to go back. And one of the best ways you can determine this is by serial ultrasound. So you want to make sure you're ultrasounding, not just saying, well, the horse is sound now, or you can start riding them again. How does it really look on ultrasound? And that gives them an objective time they can go back. Shockwave, I'm not going to spend a lot of time on this. Extracorporeal shockwave therapy, it's a pressure wave that releases energy at the site where there's a change in existing points. What that means is that it doesn't work the best in the middle of the tendon. It works best where a ligament inserts into the bone. Okay? So the change in that acoustic impedance means like there's a different density of bone than there is the ligament that's attached to it. Where those things change and become the junction between the two, that's where it works the best. So it's very useful for these insertional desmopathies, but it's sometimes used in areas where it may just have some pain relief, but isn't doing a whole lot of major impact in the actual bone. I have a few things up here. Some of them have been used in the past. Some of them really aren't used so much anymore, but they're in your book, so I'm just briefly mentioning them. Putting hyaluronic acid and the polysulfate glycosan glycans into a core lesion has been done in the past. Really, we're not doing a lot of that anymore. Tendon splitting, very uncommon, I think, nowadays. Occasionally useful for a core lesion if there's a lot of pressure in it. Kind of the equivalent of compartment syndrome, but most of the time you don't see tendon splitting. Proximal check ligament desmopathy, desmotomaming. Now we do that for flexural deformities. Okay. We don't do that to take strain off of the superficial digital flexion tendon. But it was one of those things, people were cutting the check ligament because they thought it would take the strain off of that ligament. In fact, it just caused a bunch of suspensory injuries. Now this thing here is the reason why I really have this slide here. And have you guys seen racehorses with those little white dots on their legs? Horse people? Okay. So what that is pin firing or blistering. The idea of these trainers and vets used to put this irritant or put this basically the little pin that they make the mark with onto the leg with the idea that they're creating a bunch of inflammation and you're stimulating the healing process of whatever. And really there's absolutely no evidence that works at all. And what they decided was really happening is that when you pin fire these horses, you could then tell the trainer, okay, he needs off until this day. And the trainer can see something. So it's not the pin firing at all that was helping these horses, it was rest. So don't do this. Don't do this, don't do this. If you do this, I'll find you. So don't do this. We're not pin firing horses anymore. You know, no one's really believed that did anything for, like, since before I was in vet school. We'll just start this and we'll take a little break. Alright, so regenerative medicine. We talked about all the normal ways, like the cold therapy and the pressure bandages and things like that we've been doing for years. But one of the newer forms of treatment is regenerative medicine. The idea of that is that you're trying to create a tissue that's closer to the original tissue type that was damaged. So you're restoring normal, ideally biomechanical function, and you're creating something that was more akin architecturally to what it originally looked like. So 3 things are involved in regenerative medicine. Not all types have all 3, but scaffold, growth factors, and self-population. I'll talk about a couple different types of regenerative medicine, but usually when we're doing these, we're doing them as an ultrasound-guided intralesional injection. So like, for example, here's an ultrasound of a superficial digital flexor tendon. You see this hole in the middle here? Okay. So, and the little white things here are actually air bubbles, because what you've done is you've put a needle directly into the lesion using ultrasound guidance and injected something in. What that something is going to be, we'll talk about next. But basically, you're directly injecting something into the hole in the tendon. The most common things we're using nowadays, and there's a few others I'm not going to make you listen to, but what we're using nowadays is either platelet-rich plasma or stem cells. Okay. So platelet-rich plasma we'll talk about as PRP. This has been around